Hi, this is Mrs. White, and this lecture involves the care of the patient with burns. As always, you can pause and look at our learning objectives to see what we are expected to get out of this, and at the end of this presentation, what you should understand and be able to do. Okay, so burns occur when there's an injury to the skin or any of the other tissues of the body that can be caused by heat, chemicals, electric current, radiation, even cold. The patient with a burn injury may have a multitude of problems, and most burn injuries are preventable. There are 486,000 burns a year, of which 40,000 patients with burns are admitted, and the children and elderly are most at risk of death. Because of the preventable nature of most burns, prevention programs are very important, as is teaching prevention. The person who experiences burns can suffer a lot of problems as a result of the burn. But we do have some advances in burn care that are allowing us to have better outcomes for our patients. But despite that, we have to understand that the person who has burns is at risk for many complications, including hypovolemic shock, sepsis. All of this can lead to hypotension and hypoperfusion. So any critical patient needs aggressive enteric nutrition to make sure that there is enough glucose available for delivery to the cells. Additionally, we have to make sure we know how to perform burn care and care of any grafting sites. And I did put a picture here of ECMC, that's in Buffalo. That is our local burn center for adults. When one considers the pathophysiology of a burn, no matter what the cause, you need to be aware of the three different zones. So there is the zone of coagulation. That's the point of maximum damage. This tissue is lost. The zone of stasis, where salvage is possible if there's enough perfusion, so it can go either way. And the zone of hyperemia, this will resolve. This is like a sunburn. The prognosis of the patient with burn injury really depends on these that are listed here for you. The age of the patient, as we know that the young and the old are much more sensitive to fluid loss and the effects of infection, and less likely to be able to compensate for what's going on. The depth of the burn, so the nomenclature has changed. Now we say partial thickness, full thickness, and superficial, though it used to be first, second, third, and fourth degree burns. The total body surface area, there's a localized insult, but then a systemic inflammatory response. Location is a factor, especially for recovery. The face, if there's burn injury there, you're more likely to have inhalation injuries, which can increase mortality. There's an issue with the loss of functionality and the need for rehabilitation. The type of the burn that the patient experiences also can affect the prognosis. For electrical burns, what we see on the surface may be just the tip of an iceberg for the damage that's been done beneath the skin and throughout the muscles and other tissues throughout the body. And then we need to look at the patient's comorbidities, things like heart failure, diabetes, renal disease, and their ability to withstand the treatment for severe burns. Geriatric mortality is an important consideration. So folks who are over the age of 60 are at greater risk for dysrhythmias. Folks who may already have COPD or other lung injuries or diseases, they already have impaired pulmonary function. The older adult also has thinner skin and potentially already impaired nutrition. They're more accident prone and more likely to be involved in a fire. Here you can see a cross section of skin, And remember, we do classify burns based on the location and the depth of the burn. This is a good slide to look at and try and figure out what's happening. So you can see the superficial partial thickness burns, which is the old first-degree burn, that just goes into the epidermis. Deep partial thickness goes down into the dermis, and full thickness is a third and fourth degree. That's what it used to be called. Goes down into the fat, muscle, and down to the bone. In the next few slides, we'll pick them apart just a little bit more. Okay, so for the superficial, there is redness. There is no blistering, although, to be more correct, there's no blistering in the first 24 hours. So blistering can occur down the line, but it would not be within the first 24 hours. So no vesicles at that time. It's superficial epidermal involvement. There's erythema that can blanch. It may look like the sunburn again. So if you see redness, intact skin following a burn, we would say that is a superficial or first-degree burn. We do not use superficial burns in our calculation of total body surface area that has been involved. So this has no role in the rule of nines. So remember that. You can cause fluid overload if you calculate fluid resuscitation on this. Peeling is okay, and these will not scar. Deep partial thickness burns used to be called second degree. At this point, the epidermis and the dermis are involved. Fluid-filled vesicles are red, shiny, and wet. This is the most painful. At this point, there are nerves exposed to air, so that's why it's so painful. There are blisters. Again, this is a wet, weepy wound. It may blanch. At this level, if the hair follicles are burnt, they will come back. However, there still may be need for debridement or grafting. The full thickness wounds, which again used to be called third or fourth degree, includes all of the skin elements plus the nerve endings, etc. The colors can vary, but this is a dry wound. This lacks sensation, so this is a painless wound. This means that it's more worrisome. There's, again, nerve damage, hair follicles, and sweat glands are destroyed. Let me just fix this. There's a typo on this slide, so I'm try and fix it, but there should be an H in there for Eschar. Well, it won't let me fix it on the fly here, but it's Eschar, E-S-C-H-A-R. So Eschar can act like a tourniquet. There's going to be capillary leakage, so this means that there's going to be leaking in the interstitial space, which can place pressure on the underside of the Eschar. For full thickness wounds, we need to consider electrical burns, and you can see there is a picture of an electrical burn there, and you can see the entrance and then exit wounds for the electrical burns. There's increased risk for shock and myoglobinuria, which is when the muscles are destroyed and the myoglobin and red cells are in the urine. So this is something we'll talk about further as we go along, but just to be aware of that to start with. Now, most burns are actually a mixture of different depths. So remember, when counting the burn surface area, remember not to include any superficial burns. You can see here that this person has a mixture of some superficial, some partial thickness, and some full thickness burns. As far as the location of the burn, we've mentioned, and I'll say again, that on the face and neck, we worry about the respiratory compromise. The respiratory complications can include upper and lower airway burns, and therefore careful assessment and monitoring of the patient with potential intubation should occur. the total body surface area is not an adequate indicator of smoke inhalation. And our chest x-ray will be normal initially for patients with respiratory compromise, as may the ABGs, so you need to monitor them closely. The hands, feet, joints, and eyes, we worry about these because of the loss of function and the need for rehab. And remember that cartilage and the nose, they really don't have blood supply, so they're harder to heal, which puts them at increased risk of infection and delayed healing. And of course, the buttocks and perineum are exposed to urine and feces, which can make it hard to heal them as well. When it's time to calculate the TBSA, remember to never include these superficial wounds because it will overestimate. And also only expose the areas one at a time, not just for privacy, but also for thermal integrity. And you're responsible to remember the rule of nines. It is the most common and quick method of determining burns. Basically, we divide the body into areas of 9%, and this isn't as accurate in children. So for children, we tend to use the Lund-Browder. This is more accurate for them because it takes into account the size of the head and different variations in body shape with age. Again, this is not something we necessarily do in 214, but you need to be aware of it. The total body surface area of the burn is very important because as more of the body is involved in the burn, there is going to be more of a systemic inflammatory response. So we've mentioned this in our class, but as a reminder that the cytokine rush can cause clotting and leakage. This can lead to DIC, ARDS, and fluid shifting. So once we reach 1/3 of TBSA, then that's considered a major burn, which will have local and systemic inflammatory response. This leads to hemodynamic instability because whatever fluid we give can leak into the extravascular area. So what is hemodynamic instability? It's hypoperfusion. It's their map. They lose their capillary integrity due to the leaking. And despite all the fluids, they can still be hypovolemic. We end up with shifts from the intravascular to the interstitial space. So the protein, albumin, can leak out, and that also helps us with integrity of our vessels. So this is not a new concept at this point. However, just a reminder of the cytokines and the clotting and the leaking. So as we start to go into the phases of burn care management, I just wanted to mention that thermal burns are the most common type of burn. So when we look at burn management, this is what we're generally talking about. These would be things like flame, flash, scald, or contact with hot objects. So things like in the bathroom and kitchen are very common. And then there's general treatment of burns, which we will go into a little bit later on. But right now we're going to start to talk about the phases of burns. So there are 3 phases. There's the emergent phase, the acute phase, and then the rehabilitation phase. The most time is spent on the first phase because this is when the person first presents, and we need to make sure that we are giving them enough fluids and saving them from dying of hypovolemic shock. To the next phase is the acute to intermediate phase, and then the rehab phase. So the first 2 to 3 days would be the emergent phase. So we're going to start talking about that now. Okay, so the emergent phase is from the time of the burn injury to about 72 hours after the burn occurred. At this point, there are life-threatening injuries and problems related to the burn itself. This period ends when fluid mobilization or diuresis begins. Hypovolemic shock is the greatest threat in the emergent phase. There's massive shifts of fluid out of the intravascular space. Sodium, water, and albumin all move out, causing the third space shifting, and then also lose fluids from evaporation because of the loss of skin, up to 30 to 50 mLs of fluid lost an hour. So we need to monitor our patient for signs and symptoms of hypovolemic shock. Hemolysis of the red blood cells can occur, which worsens renal function, causes thrombosis. The hematocrit is elevated during this time due to fluid loss. Now, hemolyzed cells release potassium, and then sodium decreases as it moves into the interstitial space. Although there is a huge risk of infection, this is truly not the priority during the emergent phase. We need to keep the patient safe and use aseptic technique, but our biggest concern is that to circulation and hypovolemic shock. Upon initial presentation, we need to worry about the ABCs. Airway is most important. So if they're responsive, it's ABC. If they're unresponsive, it's CAB. We need a carboxyhemoglobin level. We overgive the oxygen to force the carbon monoxide off the cell. So this is why we give them 100% oxygen. They may need intubation. 2 large bore IVs for access. We need to be concerned about the C-spine, especially for falls, electric burns, trauma. Remove the clothing that doesn't adhere, especially if there's chemicals involved. Warmth is key here. We want to make sure that our patient is warm to prevent fluid loss and also prevent some of the complications with shock. So the treatment really should go in this order. Assess their ABCs, assess for inhalation injury, supply oxygen, prepare for intubation if required. So if there's circumferential burns or a large total body surface area, remove any non-adherent items and garments, and then dry dressings are applied unless the area of the burn is less than 10% total body surface area. Then you can use moist. However, most severe burns obviously are more than 10%, so dry dressing is what we would use. Do not use ice. 2 IV accesses, which we will begin fluid replacement. You'd want to place a catheter if it's greater than 15% total body surface area. Make sure that we're managing the patient's pain, and then assess for any other injuries. You guys will need to watch for changes in level of consciousness, as burn patients are generally awake, alert, and oriented and cooperative, and then tend to deteriorate. So our airway is the most important consideration. So airway, breathing, and circulation. Circulation involves getting those IVs and getting those fluids started. Chemical burns are from contact with acids, alkalis, and organic compounds. Alkali agents are lipophilic, and they penetrate the tissues more rapidly than acid. So they are more difficult to manage because they adhere to the tissues. Organic compounds can also cause toxicity as well as burns. And damaged tissues secrete proteolytic enzymes, which lead to further damage. So treatment for here is to remove all clothing and brush dry chemicals off the skin before thoroughly flushing the area with large amounts of water. We do not want to add water to an unknown substance because that can actually increase the reaction. And a little step here to be aware of is that prevention is very important. And how do we prevent chemical burns? By storing chemicals safely and handling chemicals safely, especially in the workplace. Most of the patients who suffer from chemical burns are those who are employed working with these chemicals. You can see here, this is basically the Morgan lens. We have lactated ringers that's applied to the Morgan lens, and you irrigate until the normal pH is restored. We would not do this sort of irrigation if there was a laceration, penetrating wound, or thermal burns. So this is how we would flush an eye. So smoke inhalation can cause a lung injury. This can be caused by the chemicals and or the heat. So when a person is involved in a fire, their sympathetic nervous system is in play here. So fight or flight, they're breathing faster and deeper. So they're potentiating the damage. There may have been exposure to toxins in the smoke and things that are burning. So if you think that there's a pulmonary injury, you can assume that you're going to have a worsening assessment. So whatever assessment you see there at that time, you can just assume it's going to get worse. In the upper airway, is above the vocal cords, there could be thermal and chemical problems. So these are in areas of the mouth, the oropharynx, the larynx. You may see mucosal injuries like redness, blistering, edema. Eschar can constrict the airway, and edema can narrow the airway. We need to be worried about stridor, hoarseness, dysphagia, copious secretions like drooling, retractions, and obstructions. In the lower airway would be our trachea, bronchioles, and alveoli. These are more likely if the patient's in the enclosed space or clothing caught on fire. So signs of a potential lung injury would be altered mental status, carbonaceous sputum, dyspnea, facial burns, singed nasal hairs, hoarseness, or wheezing. So those are all listed on here as well. So pulmonary edema may not occur for 12 to 48 hours after the injury. So if we see that, that would be ARDS. So things we need to figure out as the risk of carbon monoxide. Are they able to talk? If the person is hoarse, they're going to need intubation. It may be your first and only attempt. The ABG doesn't tell us about the worsening because of the effect of carbon monoxide. Anybody who has pulmonary injuries will need a bronchoscopy. It's in the next couple days. It may be done earlier. It really depends on the patient's status, but it is the gold standard to diagnose. But there's a cardinal sign there. Carbonaceous sputum is a cardinal sign. So that means if they're coughing up soot. So this is just a slide that kind of details the overall look at an airway injury. So there could be burns and injury. There could be a direct lung injury. Inflammation can lead to edema. And remember the cilia, which help us bring up and cough effectively. Those could be damaged or lost. Loss of alveolar surfactant can result in atelectasis, and bronchoconstriction can also narrow our airways. So if we have a mild airway injury, then they have basically a cough. We would give them expectorants to get the toxins out, 100% humidified oxygen. A severe airway injury, they would need endotracheal intubation, a ventilator, bronchodilator, suction, and then monitoring of their ABGs as they went along. Okay, so carbon monoxide poisoning is basically it's called metabolic asphyxiation. Could be from carbon monoxide or cyanide. Causes impaired oxygen binding. So we spend our time on the carbon monoxide end of this. So carbon monoxide is loved by the cell more than oxygen. So we call that an increased affinity. So we do have a blood test to check, but do not wait for the results. Now this covers not only fires, but any other carbon monoxide issues. So in our area, as the weather gets cold, we tend to see carbon monoxide injuries and poisonings and deaths as a result of ineffective clearance of basically exhaust from generators and furnaces. So the normal carboxyhemoglobin level for non-smokers is less than 1.5. Smokers can be up to 15. So we need to be concerned about the carboxyhemoglobin level. And that meme that's down here, this was made by a student of mine last semester at my when I asked her to, because I had an epiphany, if you will. So just thought it was cute. All right, so the half-life of carboxyhemoglobin in the blood is 4 to 6 hours, but we can reduce that time to 35 to 70 minutes if we give them 100% oxygen. We can also use the hyperbaric oxygen chamber. And there is a pulse carbon monoxide oximeter, and that is seen right here. Actually, believe it or not, many ambulances and most ambulances with the fire companies especially, their machines actually can read carboxyhemoglobin. They just need a separate finger probe. So initial burn management, you can see here, making sure we have their height, weight, allergies, past medical history, baseline ETOH, and tox screen just in case of withdrawal may or may not be ordered, just depending on the circumstances. They will need a tetanus booster if you cannot confirm that they've had one in usually the last 5 years. So when in doubt, they will give the tetanus vaccine. If they have an electrical burn, we need to clear the C-spine and do cardiac monitoring. You can have a delayed dysrhythmia. We need to consider the need for a transfer to a burn center. So the recommendations are in your textbook, but in general, 10% total body surface area, any burns of the face, hands, feet, genitalia, perineum, or major joints, any third-degree burns, electrical burns, chemical burns, inhalation injury, burns with trauma. So basically all burns outside of minor burns. And then of course the children would be a special case. So we're going to talk a little bit more now about electrical burns. So electrical burns, the severity of the electrical burn really does depend on how intense the voltage was and the tissues that were in the path and current pathways. So not only how strong, but how long was the patient exposed to it? Is there a thermal burn as well? Electrical burns from an electric current can cause direct damage. So you need to identify the entry and exit areas, and the tissue that's in between is most directly damaged and can cause muscle breakdown. So you need to figure out and ask yourself which organ systems were involved, which tissues were involved. And the patients are often thrown, which is why we need to manage the C-spine, fractures, any head injuries. The patient, if you are at the scene, would need to be removed from the area, but remember, your safety is first. Cardiac monitoring is critical for these patients. What you see on the surface is rarely the story because of how the electric current travels through the body. So if you look at this picture here, the person was burned over here on the left hand and it traveled through and out the right finger. Urinary monitoring for myoglobinuria and hemoglobinuria is very important because of the risk of rhabdomyolysis. So let's talk a little bit about rhabdo. So massive muscle breakdown causes myoglobin to be released from the cell. It's small and it gets caught in the renal tubules. This can lead to atubular necrosis. And that can lead to renal injury and eventually renal failure. This leads to hyperkalemia. Hyperkalemia can give us an increased risk for dysrhythmias and cardiac arrest. So right there, you can see the picture of the muscle breakdown and causing all of those problems with my poor little kidneys. And no matter how healthy a person is, there's always decreased cardiac output with burns over 45% and increased workload on the heart. Mind you, the cytokines are causing vasodilation, despite the sympathetic nervous system causing vasoconstriction. So at this point, the fluid is just leaking from the vessels, and as a result, we need to give high amounts of fluid to just even keep the patient perfused at the minimum standards. So hypovolemic shock is a very serious concern in the emergent phase of burns. And to look at what happens to the electrolytes, it's very important that you understand that there are fluid shifts. There's in the emergent phase, and then I have listed on here the acute, just so you can compare and contrast. Hyperkalemia due to cell destruction, hyponatremia because of the loss of plasma. This will be a struggle to keep the sodium levels up in the emergent phase. So when you have a loss of fluid, you end up with a higher concentration of RBCs, so the hematocrit increases. And if we see that hematocrit at a super high level, we have to understand that we need to thin it out. It means that they are not getting the fluids that they need. So we would anticipate increased fluids. So after a few days, as the person starts to diurese, all of the fluids that had leaked into the interstitial space now come back. And you dilute so much that you have low hematocrit and low potassium. And at this point, you may be giving blood and potassium supplements. So you are basically chasing these electrolytes and the fluid balance from the word go. So fluid resuscitation is a big deal for burns. And this is a big deal for all the reasons we've mentioned. The risk of hypovolemic shock in the first phase right after the burn. So we want to prevent shock and multiple organ dysfunction because we learned under our shock unit how important it is to prevent this. We want to maintain perfusion to the zone of stasis because that is the tissue that we could save if we get good perfusion there. And basically to make sure that the patient has their best chance of survival. So anybody with a TBSA of greater than 25% warrants fluid resuscitation. And some say even 15%. So how do we get there, right? Let's do a little bit on the IV access. So we want 2 large bore IVs if their TBSA is greater than 15%. You may need a central line if they're at 30%, and you may even need an arterial line. We need to use a standard tool to assess the size of the burn, so that would be our rule of 9s. And then we need a formula, which we will discuss, to figure out how much fluid replacement we need. And then the fluids are titrated to the patient response. So lactated ringers is going to be the main fluid that is given. And again, usually it's RN-driven resuscitation protocols that we might be supplementing electrolytes and changing fluids based on assigned parameters. Okay, so let's talk about how we figure out what fluids we give. So there are 2 different ones, the ABA and then the Parkland. So the only difference between these is that the American Burn Association uses 2 to 4 mLs of lactated ringer multiplied by the kilograms, multiplied by the TBSA, and that's titrated to the urine output that we want. Parkland always uses 4. So an electrical for ABA, you will always use 4. So you will be told for American Burn Association that they will tell you whether it's 2 or 4 or say that it's an electrical burn. However, Parkland, it's always 4. So half of the fluids you give in the first 8 hours, the rest you give over the next 16 hours. So let's look at Parkland for a brief moment. So Parkland's 4 mLs of lactated ringers per kilogram times the total body surface area We give half in the first 8 hours, and then a quarter in the second 8 hours, and the final quarter or 1/4 of those fluids in the final 8 hours. We need to assess for adequacy of the response. So what does that mean? What's adequacy of response? We want the urine output at least 0.5 ml per kilogram per hour. We want to keep the MAP above 65, the blood pressure above 90, and the heart rate under 120. So those would be the goals for fluid response. If we give too much fluid, the person can end up edematous, which leads to hypoxia. They can go into pulmonary edema, congestive heart failure, and even compartment syndrome as those fluids push against eschar. It's important to understand the medications that would be given. So again, IV analgesics. IV is the preferred method because of the absorption and destruction of the tissues. So IV medications would be the most common, and they should be opioids. So things like morphine, benzos. We need tetanus immunization if it's not been at least 5 years, but literature really says 10. But the doctors they will guide you on that. We need to make sure we have venous thromboembolism prophylaxis. So heparin is generally used, or low-dose heparin. And if they have a high bleeding risk, then we still need to worry about prophylaxis. So these would be things like compression, SCDs, graduated stockings or TED hose. Antimicrobials, we do not give systemic antibiotics initially. We use a lot of local treatments. So silver dresses, Silvadene, Mafinide for our wound care. So remember, IM medications are generally not recommended for burn patients. Of course, the tetanus would have to go that route, but otherwise we would really want to have IV medications for pain. And don't forget that we need to have early enteric nutrition. We need to get that nasogastric tube dropped. So compartment syndrome can occur anytime that we have decreased the ability of the body to perfuse to a certain area. So we do talk about this a lot more under musculoskeletal, but basically for deep dermal or full thickness wounds, that skin is no longer elastic. It doesn't move. And this can lead to basically edema beneath the burnt tissue, so fluid replacement. And then this causes basically the tissue pressures to rise, which makes it hard for the body to perfuse the area and impairs the circulation. And then if they're around the chest, we can impair basically how the chest wall moves. So if that's the case, we might need an escharotomy. So think about this. Now, you would have now additional wounds to deal with on top of the burns. So for compartment syndrome, you have to watch the distal pulses, especially distal to the burn area. Compartment syndrome is a medical emergency and warrants a call to the physician. So the next slide is pretty gnarly, but this shows you an escharotomy. So basically you can see where they've gone through and they've relieved the pressure so that the tissues can perfuse. And this patient here also has, this is a fasciotomy where you can see it's not eschar that's there, but instead just the massive edema. So that's a fasciotomy where they cut that to relieve the pressure to allow basically perfusion distal to that area. All right, so let's talk about organ damage. Okay, so organ damage, the kidneys, of course, they can have hypoperfusion and also myoglobinuria, hemoglobin, which can cause the atubular necrosis, and then rhabdo. And then, of course, our immune system, we have already a loss of our barrier, a lot of invasive procedures, including central lines, catheters, and the like. We have the cytokine storm, which leads us to body-wide inflammation, and then the increased risk of sepsis. Okay, and thermoregulation, we lose the skin integrity and we're given a lot of fluids to the patients. So burn ICUs are warm. They need to be. There needs to be an increase in the ambient temperature. So this is why it's so important to keep the patient warm. There needs to be, basically, we don't put wet dressings in the emergent phase, and they're not recommended because they cool the patient down. So we put dry, sterile dressings on. And remember the role of hypothermia, that it can cause worsening coagulopathy. So we definitely need to keep our patients warm. And we also talked about warmth and its relationship to acidosis as well. So keep your patients warm. When you're doing dressings, make sure you're only exposing the areas you need to expose. When you're doing your rule of nines, the same applies. Often we will use fluid warmers when we're giving large amounts of fluid. All right, so here's trauma's lethal triad, which I keep talking about. So basically, as the patient gets colder, it's hard for them to stop bleeding because their platelets become dysfunctional, their clotting factors are inhibited, and then we have the inappropriate clot breakdown activation. So this is a universal law. Low core temp, decreasing pH, cytokine storm. This means as the core temp is decreased, they're going to do poorly. One of the next things we need to consider is Curling's ulcer. So we've called ulcers, stress ulcers, and such throughout our time together so far. So now under burns, we have a different type of ulcer. It's called a Curling's ulcer. It is an ulcer that is seen in burn patients. So this is a way that sepsis can come, as we discussed under shock. But so with the burn patient, it's just called Curling's ulcer. And all of the same treatments still apply. So here you have the basically H2 receptor antagonists, so Pepcid, Zantac, pantoprazole, early enteric feeds. So how do we get early enteric feeds for our patient? Well, we use a nasogastric tube. So if their total body surface area is 20 to 25%, they would need a nasogastric tube. Anybody who's intubated, because it does prevent aspiration. It prevents our patients from going into a catabolic state, prevents Curling's ulcer, and also prevents bacterial translocation. Our patients who have burns have severely increased caloric needs, up to 5,000 calories a day, or maybe even in excess of that. So if we provide them with enteral nutrition in the first between 6 to 18 hours, they tend to do better. They need these calories for wound healing, for the storm that their body is in. So basically what we want to do is maintain 5 to 10% of their pre-burn weight, because if they lose more than 10%, they may have a poorer outcome. We want to make sure that we keep them in a glycemic control. So oftentimes they'll have an insulin drip. And then again, their calorie needs are greater than 5,000 calories a day. It is very difficult to eat that number of calories. So this is why we use nasogastric tubes. In fact, one would not really expect a patient who just suffered severe burns to be able to even consider eating all of that calories. So before we go into the second stage of burns, some things that I'd like you to think about, that once the patient has a patent airway, effective circulation, adequate fluids on board, we need to worry about wound care as well. So strict asepsis, protect the patient. Debridement may be local at the bedside or require the operating room. So often because of the instability of the patient, wound care isn't the priority in the first phase of burns, but pain control is very important. Our eye exams for facial burns are important, as well as no pillows for ear burns. And we want to extend and elevate the arms. I want you to start to consider, as we go into burns and loss of function and then into musculoskeletal, the need to preserve the function of the extremities, right? So we want to put them in basically, I'm trying to think of the word that I want to use. The word just came to me. So extension, because flexion is the enemy of function. I want you to remember that we want things to be basically healed in an extension so that we don't get contractures. So on to the next phase, the acute phase. This starts with diuresis and ends with wound healing or grafting. So at this point, this tends to happen about 48 to 72 hours, based on basically the urine output. Diuresis is very significant in this phase, and it's expected. No need to call the doctor because you see them moving into this phase, but you do need to monitor the electrolytes. You need to be very vigilant. The person will experience less edema as the fluid shifts back into the intravascular space and is diuresed out. But because of the massive influx of fluids, you need to monitor their sodium and potassium levels. Sepsis becomes a huge concern at this time, so the person will need meticulous wound care. Grafting can occur at this area or at this time frame, and so we'll talk about all of that. So remember, keep the skin separated when we're wrapping things. Keep those fingers separated or else they will heal together. All right, so some of the grafting information is here for you. Silvadene is a standard, at least it has been up until this point. It's applied to all areas except the face. It can cause neutropenia though. And mafenide penetrates eschar. You may use other autolytic debriders as well. So grafting, we aim to start grafting them around 96 to 120 hours after the burns, because after 2 to 3 weeks, you'll end up with worse scarring. And early grafting is better, not just functionally, but cosmetically. So some wounds, you will know right away that there's going to be grafting. Remember, we need to use sterile technique for dressing application. And if somebody has a large total body surface area, it can be hard to graft. They may need to have multiple operations. And there's something called BioBrain that we can put on. It's a temporary cover to protect the wound and keep it viable. Okay, so some things for wound care that you need to consider. The person can actually shower. They could have a once daily shower and dressing changes in the morning and the evening. And some of our newer antimicrobial dressings can be left in place from 3 to 14 days, so that's pretty exciting. Infection can cause further tissue injury and possible sepsis. And the source of infection generally comes from the patient's own flora. So think about those things that are living in the skin, the respiratory tract, and the GI tract. And there's a couple different methods of wound care. So the open method is when the topical antimicrobial is applied, but there's no dressing placed. So this is usually for faces. And then we have the multiple dressing changes or clothing methods. That's when they put sterile gauze laid over the topicals. And again, those could be every 12 to every 14 days, depends on exactly what they're using. So I added this for you guys as well. So for wound care, this nurse right there is applying silver to moistened gauze for her wound care. So basically, if you're using open burns, you should definitely be wearing PPE, and this includes your hats, masks, gowns, and gloves, and using sterile technique. This is to protect the patient. There's different types of grafts that can be used. And again, some grafts we know right away that we're going to use need to be grafted, but some not so much. It needs to go on. So we use cadaver grafts. Those are very expensive. Tilapia can actually be used. That would be called a xenograft, which I think is on another slide from here, but just to kind of bring us to it. So BioBrain we talked about, keeps the wound beds viable. We even have some newer ones coming. This is a picture of a split thickness graft that's using meshing. So you can see how they're able to kind of spread that tissue out so it can cover more surface area. Okay, so here is actually the list of all the different types of grafts. So the homograft or allograft is from a cadaver. Xenograft is from an animal. Could be pigs, tilapia. The BioBrain for temporary wound coverage and protection. And now we have something called the CEA, Cultured Epithelial Autograft. Now this, guys, is cool. So basically they take the person's skin and grow it in the lab. So there won't be a rejection. It's better meshing in general. But the goal in the grafting is to make sure that the tissues are not touching each other and prevent contractures. Okay, so this is just a nod to some of the fluid balance issues potentially in the acute phase. I decided to focus on some sodium and potassium. So sodium, we need to continue to watch the sodium levels as we go into the acute phase, especially if the person has diarrhea, GI suction, they can become hyponatremic. Also, if they have excess water intake, so if we've given them too many fluids. And then they may become hypernatremic after the fluid resuscitation if their tube feeds are wrong. So if they have like isoosmolar tube feeds and they really shouldn't, or inappropriate fluids. So basically, if we have hyponatremia, the treatment is to get their, basically offer that. And then if they're hypernatremic, we would restrict the sodium in IVs, enteral and oral feedings. And then here is the potassium. So hyperkalemia from renal failure and large amounts of potassium from damaged cells. And then hypokalemia from vomiting, diarrhea, GI suction, if we have a lot of IV fluids on board, which is why we spoke about how the person can become hypokalemic as the IV fluids rush back into the intravascular space. All right, so the last section that we need to discuss for burns is rehabilitation. Things to think about is that the person remains hypermetabolic for maybe even up to a year. So they may have a low-grade fever. And when somebody's hypermetabolic, this means that they continue to have increased calorie demands. Compression dressings are worn all day, 23 hours a day. And they're not just to make the patient suffer. They're put on for several reasons. Among them is to maintain function in the joints and range of motion. And we do that by decreasing the scarring. And right here is some of the different scars that occur. You could have hypertrophic or keloid. So you could see the difference. Keloid is raised and hypertrophic is not. But again, the overall goal, I'll come back to show you here, see how this patient is wearing these garments. It's to maintain the function and form of his body to make sure that the scars do not get too bad so that they do not lose range of motion. And the psychology is very important, right? People who experience major burns are often coming out of a massive loss. They may have lost their home, other loved ones. They may have a lot of survivors' guilt about it. So we need to worry about those emotional needs. So in the rehab phase, just to recap that, at this point, the wounds have nearly healed and the patient is engaging in self-care. And the goals are to resume the function and decrease scarring. Contractures are always possible with scarred tissue and the joints are most at risk. You need to moisturize the affected skin and wear those pressure garments 23 hours a day and provide for their emotional needs. All right, guys, so that's the end of burns. Thank you very much.